This is the Psychcast by MDedge. I'm the voice of MDedge podcasts, Nick Andrews. Welcome to a special edition of the Psychcast by MDedge. I am the voice of MDedge podcasts, Nick Andrews. If you didn't recognize the intro music, that's because in this episode, we are doing an in-house crossover. The host of our sister show, Blood and Cancer, which is all about hematology and oncology, Dr. David Henry, will be interviewing Dr. Lorenzo Norris. This is all about psychiatry as it pertains to cancer diagnoses, which is something that Dr. Norris specializes in. It's something that he knows quite a bit about. So he will be the expert on the hot seat today, discussing hot topics as it pertains to psychiatry and hematology oncology. If you're interested in hematology oncology content, we've got plenty of that at our sister show, Blood and Cancer, which is available in the show notes. Remember, you can email the Psychcast at podcast@mdedge.com. And with that, let's enjoy our crossover episode. Please welcome the host of MDedge's Hematology Oncology podcast, Dr. David Henry, and the host of this show, Dr. Lorenzo Norris.
Welcome to this episode of Blood and Cancer. I'm your host, Dr. David Henry, and I'm joined today by another host in the MDedge family, MDedge.com, Dr. Lorenzo Norris, who is also host of Psychcast on the MDedge family electronic webpage or wherever you get your podcasts from. And he is Associate Dean of Student Affairs and Administration at the George Washington School of Medicine in Washington, D.C. So Lorenzo, Dr. Norris, thank you so much for taking the time to do this today.
Oh, well, Dr. Henry, thank you so very much. It's always great to participate with the MDedge family and do a joint collaborative podcast. So really looking forward to it.
Likewise. And so, as you know, I like to think ahead what we're going to talk about. And psychology, psychiatry, our patients, as in this case, we take care of with blood disorders and cancer disorders, many times have an underlying socio-psychological issues going on. And so I really wanted to get into them and help our listeners with the same things they face that I face in the clinic every day. And so I had a couple issues to go through with you. So to begin with, I know you wrote a really nice article on CBT. So of course I thought, well, what is that? And so fortunately you defined it as cognitive behavioral therapy in breast cancer patients. So could you talk a bit about that? What did you do and what did you find using cognitive behavioral therapy in breast cancer patients?
Sure, absolutely. One of the things to just think about, CBT in a nutshell, how you think influences greatly your emotions, which influences your behavior. Very simple and very powerful. So with breast cancer, as an example, you can use it with any type of cancer. But with breast cancer, many of our patients that we're working with are going to have what we would call dealing with a great deal of stress. Cancer is for many of our patients, an omega level event. They are literally fighting for their lives. So with that, there are going to be various thoughts associated with that. Some of those are going to be, if you will, more adaptive. Some of them are going to be less adaptive. One of the uses of CBT when working with patients is to help them think about and work with adaptive thoughts that are going to help them effectively cope as well as problem solve. So for instance, in regards to breast cancer, one of the first things that you're going to want to do is just to think about, one, helping the patient understand where they're at, because it's going to be a shock level type of thing. Make sure that they don't have unnecessary or problematic distortions, whether it's about the treatment, the prognosis, or what they themselves are capable of. And those three areas become actually rather important. Now, with a diagnosis of cancer, but again, I'm focusing on breast cancer, a number of patients are going to have a period of adjustment. All right. One of the first things that we're thinking about, not so much in terms of the application of CBT, but is where do our patients fit along a continuum of distress, if you will. They just be having an adjustment disorder or none whatsoever, just normal mood, or an adjustment disorder with depressed mood. They could actually be in the midst of a unipolar depression. They could be having, if you will, if you will, a mood disorder secondary to the effects of the cancer itself. That would be more applicable to brain cancer or pancreatic cancer. Or they could have another category of mood disorder, such as a substance-induced mood disorder. But CBT is a very useful intervention, regardless of whether a person is, if you will, having a normal syndrome of distress with very challenging diagnosis, or if they're suffering from, if you will, full-on, for lack of a better word, psychiatric symptomatology, such as a major depressive disorder.
So as you talk to them, so in my practice, I see a couple of things relevant to that discussion. I've always thought fear of the unknown is the worst fear, and fear of the known really helps you, okay, get your head around it. So they'll talk prognosis, symptoms. Tell me again, I've had medical students say to me sometimes, you just told this patient the same thing 3 times. They ask you the same thing 3 times. Well, I said, watch their eyes, because as their eyes drift off, they're thinking about their family, their financials, life and death. We got to bring them on back because they're afraid and not focused. And so I, in my amateur way, try and bring them back to the discussion to focus on what's going on, what's known, and how will we address it. Interestingly, very rarely do I get, so how long am I going to live? You know, you see that in movies and in Hollywood, and the doctor says 6 months and it's right on the button. And I rarely get that question. Have you seen that? Because I think they're afraid of the answer. And if I do, I say, well, the therapy works, you'll do better and live on. The therapy doesn't work, we've got a problem, and it can be mortal. So they wouldn't believe me if I just tiptoed around that. But we have second, third line. I can always help you win or lose. So is that a similar way you approach those kinds of conversations?
Absolutely, Dr. Henry. I think that I love how you described it in regards to that willingness. And a lot of, for the listeners out there, I mean, I love how you described it with the medical students. A lot of, in my opinion, being a physician or a healer, it's just that willingness to stay in a place with a patient and just repeat back the same thing in a different way until we've made sure that they've heard it and we've heard it. And I think that's very important. So, but to get back to that, like, you know, you have 6 months to live or something of that type of thing, I actually find that patients actually do, in my experience, do not immediately go there. There is a concept, if you will, of, and I also find that experienced clinicians, if you will, we understand that, for lack of a better word, that I wouldn't even call that denial, but just that ability to focus on what is immediate. And there are some aspects of protective denial. And how I view that is just people intrinsically know how much information they need to focus on and deal with at the moment. And why focus on something that is outside of their control? Actually, when I see people jumping to conclusions like that, or catastrophizing, that's a cognitive distortion. Black and white thinking is another cognitive distortion, as well as, if you will, maladaptive denial. We just kind of denying reality, like not discussing prognosis immediately. That would be, I would consider that focusing. Denying that you have cancer, that's problematic denial.
Whole different
all right,
problem,
to say the least. So I agree with you. I find that patients do not immediately jump to that, you know, in terms of prognosis or things of that nature, but their oncologist can do a great deal and actually level the distress just by doing what you did right there. Just you talked about speaking with your patient 3 or 4 more times, repeating the same information, not using jargon, but also not sugarcoating anything, but giving what's needed to get to the next step. And that's probably what I think is one of the things that I focus on therapy a lot. It's like, let's level the distress. Let's focus on what's needed to get to the next step. And let's not do anything that, if you're not in a unipolar depression or major depression, that could further exacerbate you developing it. So let's stay focused on the treatment. And I find that a number of patients rally behind that.
Well, very well put, very well discussed. And we will have on our webpage the reference for the CBT, the cognitive behavioral therapy. Do you have off the top of your head the reference so listeners could check it out and read it if they want to just go on the web now?
They probably, if you're referring to the reference that was in an issue of psychiatric
Yes,
that was a number of years ago.
we'll put it up on the,
We could probably make sure that, yeah, we can put it up on the website, because the actual reference you're referring to, that was part of a theme issue that I guest edited. It was called Cancer and Depression, and all the articles in there were focused on cancer. At that time, I was actually working with the American Cancer Society in regards to developing cancer survivorship guidelines for
Well, it
patients.
sounds like a very good issue in total, and yours in particular. So as we record this, of course, it's COVID era, and we're taking care of patients with cancer who have to deal
Yes.
with the cancer and deal with themselves, family,
Mhm.
and what's happening in the world. I have found much more anxiety, much more depression than I'm used to seeing
Hmm.
because they're coming to see me. Am I going to give it to them? Coming into the office, will they get it? Getting upstairs in our treatment area, will they get it? So what are you seeing and how are you handling taking care of patients with cancer in this time of our era and the COVID era?
Right. Well, first off, I hope everyone out there who's listening is safe and well, and I hope your families are safe and well. The COVID pandemic has really unleashed something on the world as well as society that people have not seen, well, basically since the Spanish flu. But I would also say, even if you've been through when I talk to some of my colleagues who are older than me, whether you've been through the AIDS epidemic or anything like that, you've never seen this. So what are we seeing out there? We're seeing definitively more anxiety and depression across the board. Across the board. We know that with the data now has been coming out that we are seeing an increase in anxiety and depression in the general population. Now, the data in regards to cancer patients, in terms of hard evidence, like really good conducted studies or things of that nature, is limited. But we can start with what we know. We can start with what we know. All right. And from that, we can extrapolate and say that, yeah, we would expect to see an increase in depression and anxiety. We know that in cancer patients, all right, depending on what study you look at, there's going to be anywhere from a 0 to 38% prevalence of major depressive disorder and a 0 to 58% prevalence of any depressive spectrum disorder. Depending on the study, all right, it's going to level out somewhere around 15 to 22% prevalence rate, regardless of cancer, of depressive symptoms, all right? That's usually across other medical conditions, so we're good with that. Now, the general rate of depression in the population, the 12-month prevalence is 6.6%, and the lifetime is 16.6. So the take-home point is with cancer, you have roughly any form of cancer, just generally speaking, you have a 2 to 4 times greater risk of developing, if you will, depression, whether you had it or not. So yes, we are absolutely seeing.
All right, so thank you for that. And treating cancer patients in the COVID era and depression, anxiety, which I agree, it's been a stress on all of us, our caregivers as well as care receivers. And then back to putting on our regular oncology, hematology hat, seeing patients when COVID isn't around. I remember a study long ago, maybe back when I was in training, I think it came out of Memorial Sloan Kettering, that fully 50% of our active advanced cancer patients are clinically depressed to the point where we should be considering intervention/medication. And if that's still true, I'm a terrible doctor because I am not recognizing and prescribing that. Can you comment on how much depression, anxiety is in the average advanced cancer patient? And should we go after that and treat that?
Okay, I definitely, when we're talking about the advanced cancer patient, I definitely feel as though we should be screening as well as treating. Now, as I mentioned before, in regards to the prevalence of depression, it can be anywhere, or depressive spectrum disorders, it can be anywhere from 0 to 58%. In advanced stage cancer, you certainly are going to be thinking that that risk is going to be high, and probably anywhere from 25 to 33%, or maybe even up to 50% of our patients can be suffering from symptoms of depression. So when we're talking about treating or referring, okay, a big question you want to ask yourself is, what screening instrument are you using? Okay, what screening instrument are you using for depression? Some people would just argue just simply asking a patient whether or not they're depressed or not would be perfectly acceptable. That is provided that you have enough time to do it and you have enough time to follow up, and you are pretty standardized with your approach. However, what most people would recommend at this point in time, because clinicians just miss it. It's well established in the evidence base. Clinicians just miss it. What I would recommend that folks consider doing is using the patient health questionnaire, either the 2-question version called the PHQ-2 or the PHQ-9, the 9-question version. All right, the PHQ of the Patient Health Questionnaire with the 2-question version is actually a very good screening tool in regards to detecting depression. It has very good, very reasonable, and I would say the good sensitivity and specificity, and that's going to allow you to actually think about, all right, or to screen for patients that you're going to need to refer for treatment. So if you have a patient with advanced cancer, as an example, and you're using a PHQ-9, all right, then that's going to give you a very evidence-based avenue in which to refer for treatment. Now, you may be asking yourself, all right, maybe I don't want to use a PHQ-9, or I'm in a community practice or a private practice, or I just don't have the bandwidth to process this. So I want to go off of just my own patient interaction, all right, and what are things that I can cue on, all right. With a patient with cancer, as I mentioned before, there's going to be roughly about 4 things that we're considering in terms of depressive spectrum disorders. Adjustment disorder with depressed mood, major depression, a mood disorder due to cancer itself, or substance-induced mood disorder. Those are the 4 things. For our audience, I want you to concentrate for right now on adjustment disorder with depressed mood and major depression. Now, when you look at the evidence, there are roughly about 9 things that some people like to think about in regards to depressive symptoms to key on. For our audience, and again, I'm assuming it's an oncology audience, but if you're in the MD family, there could be a variety of people listening to this, so all of us as health practitioners. These are the things I would like for you to focus on in particular. Non-adherence with treatment for cancer, that's obviously a big one. Impairment of their social or occupational function is the second one. And then here's another more nuanced one, but I want, similar to what we're hearing from Dr. Henry, I want my clinicians out there who've been in the front lines, in the trenches a bit more, to think about this. When your patient becomes demoralized, when they start to lose a little bit of confidence or hope, when you have those 3 things, or any one of them, in an advanced stage of cancer, with or without a PHQ-2 screening, you need to really think about, if you will, how you're going to refer this patient for treatment. So we can break this down into like 3 different, if you will, types of interventions. One of the biggest things is just to ask. If I had to pick one thing, you just ask, how are you feeling? What is your mood like? And you say on a scale of 10 to 9, and are you suffering from a clinical depression? You know, take a little bit of inspiration from Dr. Henry. Just give it to people straight and just ask. That's the biggest thing people don't do. They don't ask. Next thing, if you want to use an evidence-based scale, use a PHQ-2 or whatnot. 2-question scale, not intrusive, doesn't involve you asking the patient questions per se. You would have to follow up, but whether you're practicing solo or in a group practice, or whether you have your nurse or PA, can certainly assist with that. And then the third thing is when you're interacting with the patient, look for those 3 things that I talked about. Non-adherence with treatment, if they miss a treatment, impairment of social or occupational function, and then demoralization. And then the final thing I want to focus on, because you can't talk about depression without talking about suicide, all right, or really significant distress. All right. Obviously, you can ask, and you should ask about suicide if that is in your wheelhouse. But to be perfectly frank, most oncologists are not going to, or most people outside of psychiatrists aren't going to necessarily just routinely ask that question. But here's what I would say. It's an old one, but it's a good one. Listen to that little voice. Listen to that little voice. All right. There's, depending on the evidence that you look at, a lot of detecting suicide can be aided by a clinician listening to their own gut instincts. And what I mean by that is you feel a sense of distress. You feel a sense of lack of connection. You find yourself, wait a minute, why do I want to call that patient checkup? Why do I want to reach out? When you start to feel like this, you need to listen. And more importantly, you need to stop whatever you're doing. And then you need to make sure that that patient has a referral in place.
So they're just tuning out so badly, you're really losing the connection. That's when your little voice talks to you.
Exactly. Well said, Dr. Henry. Well said.
It's interesting. Two points on that, and you can comment. In my long career, drug abuse, narcotics, and suicide have been extremely rare. I found, I can think of one patient who was a drug abuser with cancer, but turned out she was a drug abuser before she had cancer. And then suicide, really quite rare, but I'm sure they occur and we have to watch for them, as you say. But fortunately, I'm not seeing that so much, but thanks to your comments, I want to be sure I'm watching and looking. And the PHQ 2 and 9, I'm sure with so many of us having electronic medical records, you can simply Google while you're talking to the patient those two questionnaires and say, oh, how would you answer these 2 questions, these 9 questions, and see how many points the patient gets, and worry about referral or even medication yourself if it looks like an antidepressant is in order.
Absolutely. Absolutely.
Well, I think we've covered an awful lot of ground. I really want to thank you. Any getaway thoughts? I think, we worry about the cognitive behavioral therapy. We will worry about it. We should listen to it and do it. That'll be posted on the MDedge.com website across the specialties, not just oncology. Practicing in the COVID era, stressful for all of us. I told Dr. Norris at the outset, if I broke down and started bearing my soul, he wouldn't be surprised. Fortunately, I've kept it together while talking to a psychiatrist. And finally, watching for clinically significant depression, either by your own questions, which you've outlined, or the PHQ 2 and 9. Really appreciate your thoughts today, and reminding our audience, we've been speaking with Dr. Lorenzo Norris, who is a wonderful psychiatrist, editor, and podcaster of Psychcast, so don't miss it on the MDedge webpage or wherever you receive your podcasts. He's the Associate Dean of Student Affairs and Administration at the George Washington School of Medicine in Washington. Lorenzo, thanks so much for taking the time to do this today.
Sure, not a problem whatsoever. Not a problem whatsoever, David.
Thanks again.
All right. Hey.
Yes.
Oh, David, Nick, let me just record this last part, and you can decide
Sure.
to use it or not. All
Sure.
right, because it was the second half of the second question.
Go right ahead.
All right, so here we go for it. All right, so let me get myself. Okay, so why might we, given the numbers that we've seen, why might we be seeing, if you will, an increase in depression and anxiety in this COVID era? All right, there's a couple of reasons why. One, isolation and lack of control. All right, our patients, due to quarantining, social isolation, things of that nature, they are, if you will, certainly those relationships, particularly the relationships, if you will, with their oncologist, can absolutely positively be disrupted. All right, that is a very anxiety and depression-inducing situation. One of the themes that came out of the survivorship literature when patients actually transitioned out of active treatment, one of the most distressing things for them was the loss of their treatment team and their oncology provider. It almost can't be said or overestimated the impact that the treatment team and the primary oncologist has on a patient's life. So I just wanted to make sure the audience realized that for your patients, you really, really, really are exceedingly important to them, as you are very much aware that, but on levels you may or may not fully appreciate. So one of the things that COVID does, not only is it this deadly virus, all right, that our patients have to worry about in terms of it taking their life, as well as delayed treatment, it separates them from the people that have become paramount in their life for a number of folks, which is their oncology treatment team. So when we take all of that into account, particularly, if you will, isolation, loneliness, fragmentation, as well as any type of economic difficulties that could be resulting due to the COVID-19 pandemic, we would absolutely suspect and predict that anxiety and depression in our cancer patients would definitively increase. And so, and a big part of that is them not being able to connect, if you will, I would say certainly with others, but it's definitely their treatment team.
Again, wonderful answer. Thank you very much. So Nick, I think we got all that. And
yeah, that was a great cut, and that should be no problem for me at all.
Well, Lorenzo, and of course, Nick, as always, thanks so much. And if you want to hear a bleeding, sobbing oncologist on your Psychcast sometime, let me know. No problem. Happy to join it.
Well, absolutely. I think we can have to, at some point in time, return the favor because we are, David, man, there's a lot of, as this pandemic continues, there is a lot of heavy lifting that needs to happen.